Good evening, good evening. This is Pastor Belton, Senior Pastor of the First Baptist Church of Brownsville. We want to welcome you all to our virtual health forum tonight. And before we bring our panelists on, I just want to say how grateful we are to have you tune in from all over the country to hang out with us tonight to talk about some important issues concerning our health, concerning how well we eat, how well we go to the doctor. We say our title tonight is Prevention is Better Than Care. Let me speak directly to our men tonight, especially our African American men. We must not, and we must not fail to go to the doctor to have our prostates checked, do our colonoscopies, do our physicals. We must also eat well. We need to exercise. And we need to look under our shirt now to make sure that we don't have an S on our chest because none of us do. And I enjoy talking to you and not about you. I don't like doing funerals when I see young men, especially African American men, die because they failed to go to the doctor or they failed to get a regular checkup or a colonoscopy. Getting a colonoscopy and getting your prostate checked does not make you less of a man. It makes you more of a man. You need to know. It's better to know than not know exactly what you're dealing with. You don't want to wait till it fall off, then go get it and say, well, let me go to the doctor, see if they can fix this. Let's do something about this now. So without further ado, I'm going to bring my trusted friend and great friend, Dr. Queno, and I met her about a year ago doing some health screening. So I'm going to bring her on the screen now. Dr. Queno, I'm about to add you to our stream. Amen. Greetings. This is Dr. Queno, an awesome doctor, one who is physically fit. You should see her do the squats and all that stuff. But you should see her awesome her presentation and her care and her concern for our African American men and our community as a whole, as she tries to do her part at broadening our education about our health. So, Dr. Queno, without further ado, I'm going to turn it into your hands so that you can introduce our panel and we can get started.
All right. Good evening. And Pastor Belton, thank you so much for organizing such an important discussion in our community. And I hope that this is helpful for the participants. Please feel free to put your questions into the question box, and hopefully we'll have a good time tonight. So I just, preventative care is quite important and often lacking in our community for a wide variety of reasons. I think, having discussion and open discussion about it is quite important and can bring us some education, some tools to use to help conquer our fears. So without further ado, I'd like to introduce our panel tonight. When everyone comes on, if they could give a little two-liner about themselves and about what their interests are and their background, that would be helpful. So I'm going to start with first Dr. Alfred Winkler.
Hi, I'm Alfred Winkler. I was born in Brooklyn but raised in Queens. Went to undergraduate at Princeton and medical school at Stony Brook. And I'm a urologist. And I am currently chief of urology at Methodist Hospital, which is part of the New York Presbyterian system. And it's a pleasure and an honor to participate in something like this.
Awesome. Thank you for joining us. Next, I'd like to invite Dr. Gary Carpenter. Hi, Dr. Carpenter.
Hello, can you see me?
Yes, we can.
Very well, yeah. So good evening, I'm Dr. Carpenter. I'm a primary care doctor out in Brooklyn. I live in Long Island. I was actually born and raised in Hempstead and conducted my residency at Winthrop, which is the hospital I was born in. So it's pretty cool. Things came full circle. So I'm, quite interested in this field. I'm really passionate about taking care of our people specifically, and trying to help bridge some of those disparities and gaps that happen in our care. So this is very, very exciting for me to be able to participate in this event.
Thank you for coming. Mr. Chaka Fair?
Good evening. My name is Chaka Fair. I was born in Harlem, raised in the Bronx, live in Brooklyn, cover quite a little bit of territory, was educated out in Stony Brook. I am a social worker by training. I am a person who does not want to die of anything preventable. So I try to take better care of myself than I do my car. For most of us men, we take better care of our car than we do our person. We know when we got our last oil change, the last tune-up, but we don't know exactly when we got our last medical physical or colonoscopy or any of the things that are necessary to keep us going. So I am here to try to spread that news and get as many of you as possible to the doctor so that we can all fellowship when we need to. Thank you for having me.
Thank you for the enthusiastic intro. Miss Diane Nathaniel.
Good evening, everyone. I am a stage 3 colon cancer survivor, thriver, boop, boop, 7 years med, no evidence of disease. Grateful to be here. I am the CEO of BeatStage3.org, which is a cancer fighter organization, patient advocacy to help patients get through talking with doctors when they're afraid of going through these preventative screenings, and also raising awareness to disrupt the policies that marginalize our community. So thank you for inviting me tonight.
Thank you for being here. Thank you for joining us. And last but certainly not least, Mr. Mike Smith.
Hey, can you hear me?
Yes.
Cool. Yeah, Zaki, Mike Smith. I am a 8-year prostate cancer survivor. I am a policy entrepreneur for the next 100, specifically focusing in the area of criminal justice reform, and all the disparities that exist for our people. And my presence here today is to just talk about what my experience dealing with the medical world, being a young Black man with prostate cancer. So.
Thank you for having us. Thank you for joining us. And lastly, I'm Dr. Cynthia Quaino. I'm a gastroenterologist in Brooklyn. I rep Newark. I was born and raised in Newark, but I do love Brooklyn. I moved here to complete my training and got stuck here. Most of my community service work has been involved in colon cancer awareness. So that's the part I play here tonight. So let us begin. I'm going to let Mr. Fair open up by giving us some clues as to why he thinks Black men or men in general don't often participate in preventative health care.
I think that most of the time with Black men, we think that we're going to get through. We are socialized into believing that anytime we need assistance, it shows weakness. So most of us don't go to the doctor because we think that we don't need any help. So we'll have a small situation turn into a much larger situation because of delay. So we'll have a pain or an ache somewhere and say, it doesn't hurt that much, so I'm not going to look into it or anything. I'm going to wait for it to go away. And then when it continues to escalate and get worse and worse, then we don't really want to go to the doctor because now we don't want to find out what they're going to tell us. Mm-hmm. You know, so sometimes we would rather stick our head in the sand and pretend certain things don't exist. But just because our head is in the sand and we can't see doesn't mean that people can't see us. And that doesn't mean that we are protected from the medical factors that are giving us the issues that we're having. So by us not going to the doctor, situation is continuing to fester and get worse, and then it may get to a point where there's nothing that can be done. And if we had only come in at the time where it was small or any other point before that, they might have been able to do something.
Okay, excellent. I'd like to open the same question up to the panelists. I mean, does anyone want to make a comment about access and education and other things that might discourage Black men from participating in healthcare?
So I'll just say a couple of words about access. You know, I think, and this goes for Black men and women, I think we have so many challenges that access isn't as straightforward to us. So if I see a patient who misses an appointment with me, I don't get upset because I realize, you know what, maybe that person couldn't get off work, or maybe that person couldn't get childcare. And I think that unfortunately we tend to be in that situation more often than a lot of other groups. I have to echo Mr. Fair. He gave my favorite analogy, which is the car analogy. You would never, ever, ever miss an oil change. Cars are a little different now, but everybody knows what I mean. But, you know, people don't feel the same way about going to the doctor. And I think part of it from a psychological point of view is if no one tells you you're sick or no one tells you you have a problem, you don't have a problem. So why would you go to a place to tell you that you have a problem? It's just easier to deal with everything else in life. So I think those two things are components.
Okay. All right. And Mr. Smith, do you have any comments about systemic racism and how Black men interact with the system? And I know you have had a personal experience that was not the best. So, you know, could you comment on that?
Yeah. I mean, this list could be really, really long of all of the disparities that exist and the reasons why men of color don't go to the doctor. And one of the reasons also is there's like a disconnect between the doctors and common folk, right? Even just language barriers that exist and speaking in terminologies that are totally disconnecting, especially when the doctor is of another race. There's this belief that to some degree that, you know, just in terms of like we look at pain management and how people of color are dealt with in terms of pain management versus other races. And me going into the doctor, I had a Russian doctor who initially did my exam. And once the results came back, he said, no, just let's remove your prostate. That was it. I was 42 years old, young man. And he said, remove your prostate. And I was like, are you kidding me? Like, you mean to tell me that there's nothing else that you can do? And if I didn't push back, I would have had my prostate removed, not knowing that there were actually other options available to me. And if you take the layperson that has no knowledge and don't know to push back and question, those are the circumstances that you find many men in. And being fearful and saying, hey, let's just take the prostate, period. It's much more to it, but, you know, those are some of the things and how men of color are treated in those spaces as it pertains to, you know, your prostate. So.
Okay. So we know, at least statistically speaking, that Black men participate in, well, men in general, excuse me, participate in preventative health visits about 50% less than women. When I kind of think of some of the reasons why women are more active in their health is because childbearing and those things kind of tie you up into the healthcare system at an early age. And so, you know, young men might find themselves wondering, what age do I need to go for my first checkup or annual checkup per se? Dr. Carpenter?
So, you know, I'll just speak a little bit about prostate.
Okay.
Briefly. So there's a lot of controversy, and one thing that I think we've all experienced is there's a big disconnect in terms of research and recommendations and how they apply to us. And there are many reasons behind that. So, for instance, there were new guidelines about screening for prostate cancer, but those guidelines were based on studies in essentially white men. And it changed around the recommendations without thinking about probably the group at highest risk, which is men of African descent. So what I tell my patients is, starting at age 40, get screened, at least get educated. You can have a visit, you can have someone explain to you what the prostate is, why it needs to be checked, what could go wrong. So that's my view as far as prostate.
Okay. So at 40 years old, Black men should come and get their prostates checked, or all men in general?
So it's a couple of categories. So men who are at high risk, so that's a family history of a primary male relative or a female relative with breast cancer. And men of African descent are considered high risk. So that group we start at 40.
At 40. Okay. And so what if you could tell the audience what is the prostate and what is its function?
So the prostate is a very, very small gland. And part of the challenge with the prostate is that it's hidden so deeply in the body. So it's a small gland that wraps around the beginning of the urethra tube that carries the urine. And its main function is to contribute nutrients to sperm and to produce fluid for ejaculation. So it does its job for a long time in your body, and because it's so deeply hidden, problems with the prostate aren't necessarily so obvious. They're only become obvious because of the structures that they're near. So it's right under the bladder, and the urine tube runs right through it. So typically, if you're going to have problems, it'll show up in problems with urination. But there's one unique thing about the prostate. It's made up of different zones. So the zone that affects your urination is typically not the zone where prostate cancer grows. It's the zone that's a little bit further away from the urinary system. So the only way you would know that there's something going on is by a blood test called a PSA, or by doing a rectal exam, which men do not like. It's often the number one reason why they won't go to a physician, period, much less a urologist, and it's extremely stigmatized. But I always tell my male patients, if someone in your life who's a woman can go for a pap smear, you can surely deal with this.
Mm-hmm. Can you say or describe specifically what the digital rectal exam is?
Sure. So because of the prostate's hidden location in the body, it's very, very difficult to get to. So really the only way we can get to it is by doing an exam in your rectum or in your bottom, because the prostate sits on top of the rectum, sort of on the other side of it. So the only way we can directly examine it is by putting a finger in the rectum, and through that access, we're able to examine the prostate. A prostate exam should take no more than 5 seconds. I have my patients count to 5, and by the time they get to 5, I'm done.
Okay. And what are you looking for when you do that exam?
So I'm very specifically looking for any bumps or any abnormality. So to put it in perspective, if you feel the tip of your nose, anything that's harder than the tip of your nose is an area that's abnormal. And that's really what we're looking for.
Okay. So there's a question from the audience on the screen. Why are African men at higher risk for prostate cancer?
So like many cancers, it's multifactorial. So some of it you can't control, other parts you can control. So some of it is your genetics and just the way cells are grown and dealt with in your body. Other parts of it are things that you can affect, like your diet.
So what diets put you at higher risk? What lifestyle or alcohol use?
Sure. So there are going to be some common themes that people will see as we talk about these different cancers. In general, we think that diet is very important. So we ask men to avoid eating meat in general, but especially red meat. There was actually a study that compared men from North Carolina to men from Louisiana. So the men from Louisiana had more of a seafood-based diet, and the men from North Carolina, lots of pork. And those men tend to have a higher rate of cancer and a more aggressive cancer than the people in Louisiana. So that's just a clue about how, when you were growing up, people always used to tell you, you are what you eat. And that's very true. So things like red meat are thought to be carcinogenic, and all the other things that are important for you to take care of yourself. So men with obesity tend to be at a little bit higher risk and not do as well.
Okay. And in terms of if you're so unfortunate to get diagnosed or fortunate to get diagnosed early because you did your screening, can you discuss some of the treatment possibilities?
Sure. So I just want to retouch on a couple of things that people mentioned. And I always tell this to my patients, you have to be an advocate for yourself. If you go to a physician, be ready with questions. And, to be transparent, sometimes the Caucasian patients I take care of do a better job than my patients of color. So I always tell my patients of color, when you go see the next person, be ready with questions so you can ask and learn. And, that sort of ties into screening and being evaluated earlier. And as with everything that we talk about, the earlier you're diagnosed with anything, the more choices you have and the more choice there is that you'll find a treatment you're comfortable with. So one of the biggest shifts now in prostate cancer is that we're diagnosing people at such an early stage that we can actually put them on what's called active surveillance. So when we do, the only way for you to really be diagnosed with prostate cancer is by doing a biopsy of the prostate, which is sampling of prostate tissue. And that tissue is given a grade or score. And the higher the score, the more aggressive the cancer is. The more aggressive the cancer is, the more likely we are to suggest different options of treatments. But if you wait really long and we diagnose the cancer where it's at a stage where it's escaped outside the prostate, the choices are less, and you won't be so happy with it. So in someone who we diagnose with cancer early on, the treatment choices can range for just watching you and following you with PSAs. We use MRIs and a follow-up biopsy. For people who opt to have treatment, it falls into two major categories. One is radiation treatment, and even that comes in different forms. And the idea of that is to use radiation as a form of energy to kill cancer cells. And that can come in sort of a form of X-ray beam treatments that are given over weeks. Or there are actually radioactive seeds that can be implanted in the prostate that give off radiation locally to kill cancer cells. Another option is total removal of the prostate. And that's a definitive way to handle the cancer. So those are the two primary forms, the three actually primary courses of treatment in folks with localized cancer.
Okay. Thank you. That was a great summary. Mr. Smith, can you give us some information about your experience? How did you come about to be diagnosed? How old you were, your family history, and so forth?
Yeah, thank you so much. So number one, like in my mind, cancer didn't look like me. That was just one of the myths that I had going on in my mind, was that cancer didn't look like me. I was 42 years old. And it just did not look like me. In my mind, cancer was something that old people had. and it wasn't me. I was 42 years old, had no knowledge of what was the function of my prostate. And then we have to take and consider like cultural, like my father had no conversation with me about anything medically. A lot of times women, for the most part, mothers have conversations with their daughters around their menstrual cycle, preparing them for when those things are going to come. That is just not the cultural standard for men. Like, we don't have those conversations. And so I lived my life 42 years old, not even up to 42 years old, just not knowing anything about it and learning in the process. I initially went to the doctors really because I wanted to get a colonoscopy. My father had just died from colon cancer. And so I said, hey, I need to check myself out. And in the process, someone told me, hey, just check your PSA. They literally was not going to check my PSA. They said that I was too young. I had to lie and say that my father died at a much early age in order for them to even screen me. And in screening me, before I even got a chance to do the colon exam, the prostate came first, and I was diagnosed with prostate cancer. So had I not lied and said, hey, I'm not of age, and just sort of went with what the doctor told me, we may not be having this conversation right now, right? And God knows best. And so, and when we say, like, when I think about, also, saying come to the doctor prepared with questions, many times we come to the doctor really looking for them with the answers. We don't even know the questions to actually ask, and that's just real. And so a lot of times we depend on the doctors to give us that information and to educate us. And unfortunately, in a lot of instances, we are misinformed, just through racial and systematic, racism that exists in the medical world. And a lot of us are misled. So there's a distrust as a result of it. You know what I mean? And so for me, because I had just experienced my father passing from colon cancer, like, I was really on top of it. And then for me, just even dealing in the medical world, like, I have a doctor's, a hospital sort of attitude that I click on, like, because I understand. I just have that, because if you're not assertive and aggressive in those, like, in some instances you need to be aggressive, some instances you need to be very assertive to let them know, listen, you're not going to do what you want to do to me. You're not going to talk to me any kind of way. Here's what is going to happen. And so that was just the approach that I was coming into space with anyway, right? But again, a lot of folks just don't come to the doctor with those spaces, with that attitude. And so I got on it immediately. And once they said, I went for a second and a third opinion and literally a fourth opinion, until I had a doctor who was able to sit down with me and give me the answers that I needed and told me all the options and what my risk was. And I immediately went vegan. That was just that was mandatory. I immediately went vegan, and I did a lot of holistic things before I even got treatment. And I waited literally a whole year before I actually done anything with the prostate cancer, with a Gleason score of 6, right? And so I got to my final doctor, and he gave me all the options, and I went with what fit for me. And I went with the seed implant, and that was it. And here I am today, so yeah, that was my experience.
I think you're a model patient, and you're giving us information about how we can advocate for ourselves. This is important because oftentimes, if you're not advocating for yourself, you might not have anyone to do it for you, especially if you feel unwelcome in that space. So we have some questions coming in. Dr. Winkler, if you could comment on number one, the Gleason score, and then also make a comment about what the very early and the very late symptoms of prostate cancer may be.
Sure. So at its earliest stage, there are no symptoms. So even when I do the physical exam, the rectal exam, it may be completely normal, and the only clue I have that something is going on is an elevated PSA. So that's why when I do screenings and people are hesitant about the exam, I say, please, just at least get the blood test, do the PSA. Because with prostate cancer in particular, you can get a false sense of security because you can say, I feel fine, I don't have any symptoms, I'm urinating well, I don't have any blood in my urine. So at the beginning, there are really no symptoms. The symptoms begin typically because the cancer is already spread outside the prostate. So the areas that it will spread to are some that are you can't have any symptoms from, which are swollen lymph nodes in your pelvis. But it also starts to spread to the bones in the pelvis, the bones in the back, the ribs, and you'll start having bone pain. When it gets very advanced, it'll actually compress some of the nerves and give you leg weakness, leg numbness. But we never, ever, ever want to see anybody get to that point, and no one really has to. If you go to your physician and when you go, just say, listen, do me a favor, just add a PSA. They may argue with you, but just ask for it. Be your own advocate. And I know everybody on this call has an experience where if someone advocates or speaks up for themselves or doesn't take the first answer, it makes you up your game a little bit. It makes you say, wow, all right, this person knows what's going on. Let me take an extra beat and explain everything.
Thank you. Okay, so I just want to backtrack a little bit and go to Dr. Carpenter. So in the beginning, we're wondering, when should Black men go for their first annual test? At what age is that?
All right.
Or
So
annual visit, I'm sorry.
yeah, so Black men, all men, really should begin their journey with their doctor at the age of 18. So the first time that you're considered a man, when you leave the pediatrician's office, you should be coming and seeing the primary care doctor. There's a lot of things, and especially nowadays with the advent of obesity and so many young folk, I'm seeing 18-year-olds literally with high blood pressure and type 2 diabetes. So it's of utmost importance that they start right away.
Okay, awesome. I want to take a second to introduce Mr. Cary Edwards, who was leaving a very important meeting. So we're happy to have him. Better late than never. Good evening, Mr. Edwards.
Good evening, everyone. Sorry I am late. I am trying to win the borough presidency and stretch myself real thin. But there's some very important people on this symposium tonight, people who I love dearly, who've been part of my life, and I just appreciate being part of this conversation this evening.
Excellent. So I'm going to turn over the role as moderator to you. And we're just beginning the interview with Dr. Carpenter about preventative health care. I think the next question up is, what does the initial physical exam entail? But I'll let you go with it.
Well, if you can ask the question as I get myself more acclimated, because literally I just got in studio.
Okay. All right. So Dr. Carpenter, tell us a little bit about what your initial physical exam, what are you going to be doing? What are you looking for?
Okay, so on the initial physical exam, first thing that we're looking at is, we take your height, your weight, we want to hopefully be able to review your immunization records to make sure that you're fully vaccinated for all the age-appropriate vaccines. Blood pressure, of course, your heart rate. We typically do a screen for depression. I think screening for depression is very important. It's one of the things that is very overlooked in our community. Access to mental health care there's a huge disparity there compared to our non-Black counterparts. So, that's another big piece of it. And, reviewing your family history. So that's another thing that I think that goes amiss in our community is so many young brothers and sisters have no idea what's going on. I say you weren't yet invited to the Thanksgiving table. You were sitting with the little kids table. You haven't been brought to the table where the old folk talk about all their health stuff. You know what I'm saying? So I think we could all relate to that, where we just are unaware. So I encourage them to, just try to have an honest conversation. They may be reluctant, depending on where your parents are from and, how old they are. But, it's very important that we know what we are at risk for. And that history is right there, for us to have if we just can have that conversation with our family. So that tends to be the biggest things that we discuss. Obviously, we get sexually transmitted disease screening, HIV, and things of that sort. So those are the salient points, that we go through. And then, addressing any of your complaints and addressing any, pre-existing conditions that need to be, dealt with.
Mm-hmm. Is there any blood work that you do? Anything in particular? Cholesterol panel?
Yes, so absolutely. Most annual physicals do include blood work. So I do a blood count to make sure that your blood count, your white blood count's not elevated, or that your platelets aren't low, things of that sort. We look at, your electrolytes and, your kidney and liver function, just to make sure that there's no issues there. Quite often in young folk, especially those that are overweight or that drink too much alcohol, I'll see mild elevations in the liver function tests. There's a condition called fatty liver disease, so we have to address that. That's basically addressed with diet. So I see that quite often in young folk, because, like I said, there's just this like way too much obesity in our community. The other blood tests would include the hemoglobin A1C. That test is the test for diabetes, so I see a lot of pre-diabetes, so, I get on my patients and I say, you're a little too old to be eating Skittles. You're a little too old for that. To put the Skittles down, brother. Like, what are you doing?
I know somebody on the screen that likes Skittles a lot, actually.
Yeah.
Who's that person? Just now, I'm trying to make sure who they are.
Never mind.
So it's very important that we're mindful of how much carbohydrates in our diet, and using the hemoglobin A1C, I can really get an extrapolation of 3 months worth of information with that. So patients say, "Oh, well, I had this today," and I say, "Well, you must have been having it for a while, because this is 3 months worth of information."
Mm-hmm.
So that's a very important test. The lipid panel or cholesterol panel is another test that almost everybody's going to get. So looking at the cholesterol levels. As we approach the age of 40, we can start doing a risk calculation, and I calculate your 10-year risk for having things like heart attacks or strokes. And based on that, that helps me to make treatment decisions on whether or not I'm going to be starting a statin medication, or sending you to the cardiologist, or doing another test called the coronary calcium score, where we can look and see if there's calcium deposits in the heart, which would make me have, more suspicion that there's something going on at an earlier stage, so it's very preventative based. Just from the lipid panel, you get a lot of information, and, can really adjust patients' diets, with that. And those things need to be the main test, when it's age appropriate. Of course, a PSA is always included. Once, if you're Black and you're 40, you're getting a PSA. Almost 100% of the time.
Do you, as a primary care doctor, routinely check the PSA, or do you refer them to Dr. Winkler and he checks?
So I typically check, and if there's any abnormality, or even if it's not an abnormality, but if I see a big shift, so last year it was 0.78, this year is 3.4. That might be reason for me to send you over to the urologist and see if there's more studies that should be done.
Right.
Hey, Doc, could I jump in and ask a question? When you said over 40, I mean, is there, Dr. Queno had taught me a few times years ago about the colonoscopies at 45. Is there a standard age, or is it as soon as you hit your 39th birthday at midnight, do you start to look into these things? Joking, but seriously, like, is there a certain age within 40, or are you just talking about generally over 40?
So the guidelines basically say, high risk patients, not to overtalk Dr. Winkler, who addressed this before you got on the call, but Black folk, we're considered high risk, so I just automatically say 40, Black, you're gonna get your PSA, and if you, in some rare instances, if you have a family history of somebody that was very young, that contracted it, I may consider doing it even sooner, in your 30s, and that's rare instances, but those sometimes do happen.
All right, and then also, and obviously you're a great doctor, but let's be honest. Most people go to the doctor. They're just kind of going through the motions. Is this something that people should ask for, or is it? I know you say you routinely do it, but is this something that people should ask for in the respective kind of, making sure they're good?
Yeah. So every doctor is different, and not every doctor is going to be as interested in certain groups of people as others. Unfortunately, there's a lot of literature that actually supports and corroborates that. That's not just me speaking off the cuff. If I could pull up, I got the receipts. You know what I'm saying? So it's definitely important that you are your own advocate, because I've seen far too often where I'm spending most of my time with a patient undoing what was done by another physician, and also trying to catch them up on all these things that you just would have assumed happened in this state that they never happened. There's no good explanation why.
Okay.
But from a urologist perspective, all of my patients of African descent, starting at age 40, PSA every year.
Every year?
Yes, annually.
Annually, okay.
And one of the questions in the chat is, why are Blacks at higher risk? Sometimes we know that, but we don't. We need to hear you explain that.
Right.
Yeah,
but no, go ahead.
I was gonna let you go ahead. You urologist.
So as I said before, there are a lot of factors. Some of it is your genetics, your family history, but some of it is your behaviors. So it's interesting. Everybody's going to talk about things you need to avoid, and Mr. Smith talked about the first move he made when he was diagnosed is he became vegan, because he knew that diet contributed or can be a contributor to this. So part of it is genetics, and part of it is diet and what you're putting into your body.
Could I just add to, the reality is that although I went vegan, I had an ability to have access to actually go vegan, right? And make that choice and understand that although organic or being vegan can be a thing that was expensive, I did understand also that my funeral could be expensive too, right? But there's other individuals in the community that they don't really make that connection or actually have the resources to actually make that choice. So when we talk about a space like Brownsville, and we're talking about areas in Brooklyn where people's breakfast is a bagel with mad cream cheese or chopped cheese or a 50-cent liter soda in the morning. Like this is what the meals that individuals have access to, right? This is their food. This is their health. This is what they financially can afford. So it's not as easy to transition for many individuals in terms of their diet because of just mere access to healthy options. You can go into any corner store, so in a lot of spaces in Brownsville, and can't find a banana or an apple.
I'll give you one worse, right? I'm a type 1 diabetic, and I can't even get diet soda. So that's a reality. And so these are the things that you're right, we really got to look at as it pertains to that. So that's going to lead me into my next question. What are the risk factors for hypertension and diabetes? Like again, I'm a type 1 diabetic. I've been a type 1 diabetic for 44 years. Sugars jump up and down based off of my stress and all type of things, right? But why those particular two in particular creates this conversation as well.
All right. Yeah. So the risk factors for hypertension and diabetes in our community, some of it is genetic. There's a genetic component. I have a theory that goes back to the transatlantic slave trade, which I will spare you all tonight. But definitely genetics is a big thing. Our diets tend to be higher in sodium, and that goes across the board. Whether you're Afro-Caribbean, African from, West Africa, East Africa, like there just tends to be a lot of sodium in our diets, foundational Black Americans, all the same. Just a lot of sodium, and that comes down the pipeline from the preservation of food from a long time ago, and those recipes getting pushed down the line. And that's just considered normal. That's the way we've been making it all this time. You understand? So that's part of it. Access to the gym, not going to the gym, sedentary lifestyles, definitely a huge risk factor. Just having a family history, which goes back to genetics again. Obesity is another huge one. No question. Consumption of alcohol. So patients that consume more alcohol, more than like 1 to 2 drinks a day, then you're much more likely to have issues with your blood pressure. Cigarette smokers, they also tend to have a much higher risk of having elevated blood pressures. And then, for patients that eat a lot of carbohydrates, so diets that are very rich in carbohydrates. So that's your rice, your potatoes, your bread, your pasta. Like you go to a West Indian party. I don't know if anybody's been to one of those before, but you get a plate and you get a plop of rice, and then you might get some mac and cheese or some macaroni pie, depending on which island you're calling it from. And then you're gonna get some plantains or some bun and peze, if you're Haitian. And that's just the start. You didn't even get to the meat yet.
Right.
And I got patients that eat like that on a regular basis. Like that's their norm.
And no veg, not a drop.
Right.
Maybe some steamed cabbage.
Maybe some steamed cabbage or some steamed, broccoli or something on the side, a little bit, some spinach maybe, and then they cook the spinach down till they have no nutrients left, So these are the things that we're up against, what I'm saying?
So one of the bigger things we're up against now is that, marijuana is legal, right? And so you could bun your weed, in the street if you want. How significant a factor is that in terms of when you talk about the alcohol, when you talk about maybe just abusing your body, how significant a factor is that specifically for those who now find this as, almost an everyday thing? Is that something that you look at?
Yeah, so no, absolutely. I think marijuana is controversial in that it has not been, it's like been illegal to study it. Like literally, it's been illegal to study it. So getting good data on the outcomes that come from its consumption, I can't give you any great evidence-based information on it. What I will say is that a lot of brothers consume marijuana with tobacco, right? So they're wrapping it in tobacco papers and backwoods, things of that sort. And I think that those are probably things that are more contributory. Because if you look at it from the patients, our Caucasian counterparts that can afford the legal medical marijuana in New York, they tend not to have these same issues. They might have multiple sclerosis or some cancer diagnosis or whatever, and you don't see, elevations in diabetes or blood pressure in those instances. But I think it's the way it's consumed is probably the most important thing, and also the amount of consumption, because if you're smoking all day long and you're more sedentary, you're lazy, you're not as ambitious, then it's gonna have those outcomes.
Also, let me interject there too, because we share patients, and there is something called a marijuana or cannabis cyclic nausea and vomiting syndrome. So as a gastroenterologist, I see that a lot, and that comes from chronic use multiple times a day for years on end, and you experience episodes of nausea, vomiting, abdominal pain that is so bad that it leads to go many trips to the emergency room. So now that it's legal, we're kind of seeing this a lot, and oftentimes it's a task to convince people that this is a real thing. But you can go and Google and do your own research, but that it is a syndrome that affects some people. So moderation is key in anything that you do. So let's be mindful of that.
So
I always ask them, if you're taking hot showers to relieve your symptoms, then I know for sure that's cannabinoid, hyperemesis syndrome, no question.
Absolutely.
So Ms. Green asked, is high blood pressure only related to what we eat?
No, so high blood pressure, again, it's multifactorial. So there's many, many factors, right? So race, your genetics, if you have a lot of high blood pressure in your family, you're much more likely to have it. Even stress levels can contribute, your weight, your activity level. So if you're not exercising and moving around frequently, like I said, that definitely is going to make you at much higher risk. Consumption of alcohol, but the main thing in the diet really is the sodium. So, like I said, we just have way too much sodium or salt in our diet, and it's really hard to get it out. Using the Sazon packets, Maggi packets, canned
That's my
food,
stuff. That's my
Dan?
stuff.
You know, all of those things, we don't think of it as salt. Adobo, you know, garlic salt, sea salt, Himalayan salt. I'm like, if it says salt, it's salt.
It's so.
Stop playing. Don't play with me.
So I'm going to pivot, even though I know I'm late, because, you know, one of my favorite people haven't gotten to speak yet, Miss Nathaniel. And so, you know, one I would like to, before we even get into the questions, just kind of give your journey. I try to give you 2 or 3 minutes on your journey, but, you know, I know it's going to take a little longer. But, you know, just to let the listeners know, we have an amazing woman who's been through an amazing journey and is sitting in front of us today, smiling, laughing, and giving love to students and others. So I'd just like you to kind of, you know, introduce yourself and why are you part of this great panel through this conversation.
Oh, wow. Thank you. First, let me just say, all this Black excellence in one place is just making me giddy. So I just want to say I am honored to be among some of these very fine leaders in our community. And I don't think that people understand the work that we do. And it's not noticeable enough. You don't need to be famous to get in the trenches to do this work. You become famous. The work is in everyone's bones sitting here. So I am super proud of you if no one tells you. Again, my intro, I said I was a stage 3 colon cancer survivor. So yes, I am. 7 years, you know, that's the number of completion. So I was waiting to get to 7. So I'm just praying God keeps me clear and clean. And I did promise that if I was saved, that I would spend the rest of my life in patient advocacy and raising awareness in our community and making sure that we understand that we do have a voice. And you heard Zaki mention that he had to advocate for himself to be heard. And as a Black woman, if any women are listening, I know we feel unheard. When you go, they dismiss a lot of our complaints or our symptoms as being related to menstrual cycle cramps or the bleeding. Women, we bleed from 2 places. You can bleed from your rectum as well as your vagina, and it's not always your cycle. So sometimes we believe that, oh, it must be my cycle coming, you know, every 2, you know, it's coming twice a month. And then no one looks into it any further. I was 44 when I was diagnosed in late stage 3. And at 34, I knew something was wrong. It takes a polyp 7 to 10 years to turn into cancer. So for 10 years, I felt ignored. And let me just tell y'all, I'm a beast right now, okay? So I'm making up for those 10 years lost that nobody was listening to me. And I can tell you that my symptoms were constipation. They were bloating, unmovable gas, very fatigued. I had a rapid weight gain, unexplainable, then a rapid weight loss, unexplainable. And the only thing that led me to be able to talk to you today is I was having a shoulder surgery. And they did my pre-surgical testing and my blood work showed that my hemoglobin was like level 4. I don't even know what it's supposed to be. So as you heard Dr. Carpenter say, like these panels that they get all this information from, it's worth it for us to ask, what does that information mean? What is the normal range of any of the stuff, right? So to our medical partners, like it's not enough to just say you were normal. It would be great and helpful to let us know what abnormal is. So if I fall below that, then I'm checking it, right? I'm calling you not when I'm sick, but as a preventive measure. Those panels that everyone takes is never explained to us unless it's abnormal. And a lot of times it's too late for Black people, as you heard, right? We have the underlying conditions for almost every single disease. So I just, I ended up having to do see a hematologist and do infusions, iron infusions. Because what they tell me, I was anemic. If I didn't know any better, I would just continue on with those infusions and not pushing for further investigation. I'm adopted. So I heard us talk about genetics and family history. What about those of us who have no family history? You know how many families are raising grandchildren as their children because in some way the child was 12, 14, 15, couldn't raise the child. So grandma took over and no one ever shares the information in our culture about what past things we could have been predisposed to. So there's that's another cultural issue that we battle. And I didn't know my family history. So no one thought to test me for anything further because I was 44. And back then the screening age was 50. So kudos to the USCPF for like making sure we are now at 45, and let's hope that everyone signs on for it. And by the time I could see a new GI doctor, I had rectal bleeding, followed by a major surgery to remove all my organs, remove the cancer, place them back in, followed by 8 months of chemo, 12 rounds of chemo for 8 months, 48 hours every 2 weeks. Listen, so if I'm here today, I'm just saying to you, you don't want that. 98% of colon cancers are preventable through screening. Colonoscopies are the gold standard. While mine was not the traditional, I just didn't go for my visit, I am telling you the importance of the colonoscopy, because that's what showed that I had a tumor the size of 5.7 centimeters. And in the 2 weeks that I had my surgery, it metastasized to 7.5 at the time of removal. So it was very aggressive. I would have never checked it if not for the shoulder surgery, and I might not be sitting here listening or talking, to you guys today. So as a woman, I know that we always go, but I don't think we're always assertive. I don't think we are aggressive enough. It is not to be seen as disrespectful. You should walk with your questions. We should go as a preventive measure. If something doesn't feel right, 9 times out of 10, it's not right. And again, the analogy made for cars, I'm going to say it to ladies, like we Googled the latest bag, we Googled the latest iPhone or new phone, and we need to take care and do the same research on the physicians that we're seeing. And guess what? If they're not treating you right, you can find a new physician. This is no disrespect to everyone sitting here, but if anybody is not treating you right, you move along. Don't sit and accept unsatisfactory treatment at the doctor's office or any place else. We walk out of restaurants all the time. We write terrible reviews for hair products. I think that we need to take that same and pay that same attention and energy, to our healthcare. And so I am so super proud of my men sitting here giving all this information, and any information. I'm an open book. Certainly ask me any questions you want this evening.
So I have so you just pretty much went through the whole script, so I can't even ask that question. Like somebody must have gave you that questions beforehand. I think we just lost Shaka, but I wanted to ask. So I'm gonna ask you and Mr. Smith a question. Oh, Shaka, you back too? Well, he keep going in and out. But I'm gonna ask both of you guys a question because it's two. Yeah. So I'm off. Everybody, I'm off script. So just everybody that's on the Zoom, just know I'm off script because that's what I do. But the reality of it is right. There's 2 different factors here. One, men, we don't like to go to the doctor. We don't like to change things. Dr. Queen will tell you when I had to do my colonoscopy, I try to make the most comedic thing ever because I ain't want nobody sticking nothing in my butt, right? But the reality of it is, so men on one end, we have this homophobic, we have this scared mentality about going to the doctor in terms of colonoscopies, but in general. But on your side, right, what you went through, it was now basically I want to say a lack of respect, but it's core like you wanted to understand what your health was, but they weren't giving you enough information or putting you in the right scenarios. So as men and women of color who have to go through 2 kind of different issues around their healthcare, what do you as a woman see? And then Mrs. Smith, I'd like you to jump in to tell me what you see as a man. Like how do we, because a lot of the questions are coming in the chat on how do we combat the ignorance, how we combat the fear, how do we combat the treatment, right? So what did you, being a woman of education, right, and an educator, how did you push through it outside of just saying, I know now because I'm sick, right? What created that dynamic for you?
I think hearing other folks going through the same thing, who knew that there were so many people having the same negative experience. And then I thought about, I have great health care, right? I'm a guidance counselor. I work for the DOE. I work for the city. And there's no reason you're treating me poorly. And then I had to think of all the other disparaging experiences I did have in my life that had nothing to do with cancer. And I realized it's just the way Black people are seen. And so I felt like if I want to walk out of here alive, then I have to open my mouth. if you want to be around for your family, if you want to be around for futuristic things and goals and plans and, all of the dreams that you have, then you have to take control of the situation. Was it easy? No, but once I got that first question out, or when I first disagreed with something that was said to me, it just opened the floodgates for me to say, doctors are people too. And sometimes they welcome the feedback. They want to hear from you. They don't want to always have just a person sitting in front of them just saying yes, yes, yes. Sometimes you have to ask, well, are there any options? And I didn't know. This was all like experiential, just walking through the process and sharing it out loud, and then having other people encourage me, and then having a support system to encourage me, and then reading everything they told me. I was like, let me Google that. I never been Google so much in my life. I went and bought books. I did change my diet. I had to do plant-based through the entire treatment process. And then I realized my doctors weren't going to be proactive in saving my life. Like, it was all up to me, because I was told you can eat anything you want after the surgery. What? I can eat anything I want? You just told me processed foods. You just told me red meat. You just told me alcohol consumption, smoking. You just told me all these risk factors are precursors to colon cancer. And now you're telling me after I've had this major surgery, 12 rounds of chemo, I can eat what I want. I was even told, no, go perm your hair. It's fine.
So my question now for the doctors, right? Western medicine versus Eastern medicine versus eating right, versus, what you're taught medically. Like, how, if you have a patient like Diane, do you now create that treatment? Because, don't get it twisted, I'm sure she ate a hamburger, right after. But the reality of it is how do you now, with knowing these factors lead up to it, prepare people specifically around diet? Like, how do you guys as physicians, as doctors, as caretakers say, what she heard is wrong, but yet she heard that from a doctor?
Yeah. All right. I can touch on this a bit. So, I mean, one thing, and the other doctors can let me know if they feel the same way. Very little education on nutrition while in med school and in residency. So most doctors are self-taught on these things, if they give a damn, pardon the expression, but it has to come from self, so I was mystified at the very little amount that was spent on those topics. And everything I've learned, I've had to really learn on my own. You know what I mean? Because, it's just the level of care that the person wants to put into educating themselves on these things so they can best help their patients, right? So I think understanding that the way Western medicine is, it's about prescribing pills for the most part. That's the drive behind the doctor. Prevention is important and stuff, but ultimately it's like, all right, how are we going to get these pills to these people? That's how I personally feel, and I feel like that is almost intentional, that something that should be so integral to health is left out of the one field, primary care, urology, it all matters, so MD education should have it, and should have it as a much stronger piece of the educational process, so a lot of doctors just don't know, which is why they don't spend the time to tell you things that they just are unaware of. That's just been my personal experience.
All right, Queno, Dr. Winkler, any comments on that?
I agree with him 100%. Even in my evolution as a doctor, I've moved more towards looking at people's behaviors. So your training is this person has this disease process. The cure is X medicine. The cure is X surgery. The cure is X procedure. But so many times you have to take time, which is we don't have a lot, and talk to the patient and find out what's behind the symptoms. So I'll give you a classic example for urology. We have urinary problems. So someone can come to me and say, you know what, I'm urinating, every 3 hours. I'm up 4 or 5 times a night. So over time, you learn to not make your first move. Here, take this prescription. You learn, ask 3 more questions. Like, well, how many cups of coffee do you drink? How much iced tea are you drinking? How much soda are you drinking? Let's see what we can change first in terms of your behavior, which includes your diet. That's a big thing, and see how far we get with that. But again, that's after I have seen a patient and I have all those basic labs, all that basic information to begin to understand you, and then we work from there. But definitely, nutrition is, I can't even say it's under-taught. I would say it's barely taught.
Quinn?
So I'm kind of two minds on this one. I certainly agree with what both the doctors said, but I also think that the doctor-patient relationship is a two-way street. It's 50-50, and it requires participation on both ends. I can't tell you how many times that for reflux or for fatty liver or just for overall health, where you talk about weight loss management, dietary modification, exercise. And so many times the question I get asked is, well, you have a pill to help me lose weight, or, what do you think about gastric bypass? And not to say that those things aren't viable options for some people, but I think somehow socially or medical socially, we've kind of primed people to go down that route. It's not considered in vogue to do dietary and lifestyle modifications. People think it's too much work, and people feel annoyed when they leave your office and your doctor and the doctor didn't even give me any medication. I get that kind of attitude a lot. So I think patients, about being your best advocate, you have to also want to do the work that it takes to be healthy. To create healthy habits requires intention. It requires time and some patience. Maybe to get to your goal weight, if you did it, through diet and exercise, might take you a year, but it's sustainable over a long period of time. And it's not as fast as a pill, but there's no side effects and so forth. There's so many reasons why doing it a natural way works, but we live in kind of like fast results kind of society, and people often opt for medications, I found.
So this is going to segue us into Brother Shaka, but I just first want to shout out Diane. Aren't you a plant-based counselor now? You're plant-based. If anybody in the Zoom needs some plant-based help, couldn't get her out for a couple of weeks because she was studying for this thing. But so Shaka, I'm gonna pivot into that, right? One, we got to look at the mentality of trying to get it quick, right? Then we also have to look at mentality of men having this stigma attached to them from whatever years are. So I want first you to talk about the patient, wanting the quick way out, and why do you think that happens, and then move into the mentality of why men are so, resistant to these issues, right? These almost demasculating issues, but two, why overall we don't do health. So I'm giving you three questions. I could respond to. I could re-ask them if you need, but I'd first like you to address the fact of what the doctors are talking about in terms of patients and their resistance. We lost him again. You did. All right. So Mr. Smith, I'm gonna come back to you real quick while he's doing that. Just what was the mentality? One, to even get to the point of going to see the doctor. I know you may have spoke about it before I got on, but the depths of it. What were you sick? Again, I'm late with this, right? Did you get sick, or did you say something's wrong? Did it still stop you from going to get checked out?
Yeah, absolutely not. Again, my father passed away from colon cancer. So that was the reason for me going. He passed away from colon cancer. I had absolutely no symptoms whatsoever, and it wasn't really. I had explained this to Diana yesterday that I actually looked at my father's death certificate for the first time in detail maybe a day or two ago, and realized that my father was 57 years old when he passed away. So he was a young man. I'm 50, right? So my father was only 7 years older than what I am now. And so when I was diagnosed, I was 42 years old. He died in August. I was diagnosed in June. And so But I learned very quickly from what his experience had been, what he did not do. And I knew that I was going to advocate for myself, and I knew that I was not going to go in there and accept anything that they gave me, right? And I understood early that diet was a factor. I tried to have diet conversations with doctors, but it was like I was really talking another language. Mentioning saw palmetto and lycopene, and my vitamin D was, I had a vitamin D deficiency, and what is the connection between my vitamin D deficiency and my prostate? Like, what, you know what I mean? Because there's study in connection with some of that stuff. Like, I came in there knowing some of that information, and it was individuals, some doctors even told, listen, stop taking that. What? What do you mean? Right? Like, why? And just could not absolutely give me any evidence on why. And it was really because they just really didn't have any knowledge or, evidence for themselves to actually justify, for me actually using those things. But I went because my father passed away, and he didn't have a conversation with me at all about health. Even all the way up into while he was in the hospital having the surgery, he was very secretive, did not want to talk, did not want to tell anybody about it. Like, he was very just reluctant to even have the conversation, right? And I knew that, for me, I just was not going to be that. That was not going to happen to me. And so, again, I had no symptoms. I went really for a colonoscopy because that's what he passed from. A gentleman in the barbershop. It was a barber. I'm a barber by trade. He said, yeah, get a PSA too. And I requested a PSA. They was not going to give me a PSA. Said I was too young. I had to lie about my father's age and when he passed. And then he gave me a PSA. The PSA, my numbers came back high. They did a biopsy. And it came back that I had prostate cancer. So, as I said before earlier, had I not gone through those measures and pushed back, I probably wouldn't be here talking now. And then what sparked for me again was me being so young. I started looking at my homies in the barbershop and like, yo, when the last time you been to the doctor, man? Right. I got prostate cancer. I know me and you the same age. You understand what I'm saying? I think you even older than me. So I started looking at my friends different. I started looking at my clients different. And I just was really a monster with like talking to individuals about it, and even having a conversation about the fact that brothers was running around literally with no insurance. That was a major factor. Brothers and ain't been to the doctor in years. So, all of those things was, played out for me, in this experience, and just educating individuals and getting my friends to go to the doctor, telling people in the barbershop, holding forums, having blood pressure and glucose testing happen literally in the barbershop every week, partnering with other, medical centers to come in and do that space in the barbershop. That's where the brothers at. That's our, our social club, our therapy session. And it's like, all right, here's a space where we actually can be vulnerable, right? Because it's about vulnerability and sometimes exposing and not feeling stupid, right? We don't ever want to feel stupid, right? And so we'll pretend like we know what our prostate. Yeah, I had a prostate. Brother, you don't even know what your prostate do. You know what I'm saying? Because I did. I'm going to stop. Wait, where is it? Ain't it that thing? Don't you got it? It's in your butt, ain't it? Like, yeah. I mean, listen, let's keep it a buck. Like, that's just what it is. That's just where, a lot of us. But again, the barbershop was a space for us to be vulnerable. And like, here's how we can educate. You don't have to feel stupid about it, right? Because that's just what our cultural dynamic has been in terms of educating us about our body parts, right? If we even had a condom conversation, right? Right? You know what I'm saying? Like, that may be the extent of our conversation may have been about a condom versus, prostate. You know what I'm saying? Like, that could have been, so that's just what my experience has been. So that's what I want to add to the
Did you have some pushback though, right? You're going through this, right? You're suffering with this, you're fighting through this. But even when you stepped to your brothers and you started doing all of these things, were cats still like, nah, I don't want to touch that? Like, you know what I mean?
Yeah. Yeah, there was some cats that, you know, definitely was like, what? Nah, man, I'm not, you know, doing that. And they gave the example earlier about, you know, women, you know, doing, you know, the pap smear and so forth and so on. And I was like, listen, I don't know a sister who has done a pap smear who now fell in love with their doctor, right? And so because you get your finger in your butt, that don't mean now you're homosexual and you actually trying to get with your doctor now. Like, that just doesn't logically make sense. And so that's the analogy that I gave. And
Right.
like, hold on, wait a minute. Now, how does that make it's a medical procedure? You wouldn't associate that with any other medical procedure. Now, all of a sudden, because this is what the medical procedure is for us. And it doesn't always have to be the finger in the rectum, right? It's just could be a blood test, the PSA, prostate specific antigens.
Right.
You know what I'm saying? It can be as simple as that, right? And me explaining that to brothers in layman terms, because sometimes, you know, there's this code, you know, you just have to speak the language of the people, and that's what it is. And so I think, you know, too, sometimes, you know, in my mind, sometimes I think like there's also a level of responsibility in the medical world to like really be more connected to our community, right? And our ability to communicate with our community in the language that they understand. Because again, like a lot of that medical jargon can just go over somebody's head and they won't even come back. It won't even come. It's like, I don't understand. I can't explain it, right? And not knowing how to advocate for themselves. And so for me, it was like, all right, listen, what did you say? I understood it. Let me break this down to my homies and my friends and people in the barbershop. Even if we make a comedic situation out of it, how do I make this conversation comfortable?
Right.
So you don't feel a ways and uncomfortable. And that's the deal, you know?
So Dr. Winkler, I'm gonna tell you a brief joke story, right? Because I took Dr. Quenu to CCC Church. We did a Men's Day at CCC Church, right? And I gave a great speech, and I'm like, oh, you know what? Doctors outside, you know, go outside and talk to her about colonoscopy, right? And all these men are like riled up because, you know, I'm telling this is how we're going to save their life. And the minute they saw Dr. Queno, they was like, nah, I don't know. I can't do that.
Not this sister here.
This is not. And so it's funny because even when I did my procedure, right, she said, I'm under anesthesia and I keep swiping at the probe, right? But as a male doctor, as a doctor who handles this, right, who does unfortunately have to, you know, violate people at times.
Oh, I don't say violate.
Well, you know,
don't say violate.
Look, we're in a safe space, right? Come on, we're gonna have a little, you know. But in that reality, how difficult is it to get patients to want the care? You know, because now that's the psychological side of it that, yeah, I'm seeing a doctor that looks like Dr. Quenu and I don't want her to see my privates, or better yet, now I have to have another man, a black man, actually treat me. And so, you know, I mean, Brother Smith, I know you could jump in on it too, but like there's these factors, these huge obstacles. Like, so how do you de-escalate that? How do you say, listen, you know, without creating that dynamic?
So first of all, I explain what I'm doing and why I'm doing it. And in every exam room I actually made them put a whiteboard with a marker. So everything I do, I write it out. I draw it out. I say, all right, listen, this is where your prostate is. This is the only way I can examine it. So I explain what I'm doing, and the anatomy and the reason is clear. Then, to be honest with you, I empathize with them. I tell them, look, man, I have to get this exam. I don't like it either. Okay? But I'm doing it for my health. And I do use the pap smear analogy, especially if they come with their significant other. Because I'll say that, and the significant other will give them a look like, and they're like, okay. But a lot of it is and a lot of times, if you just spend an extra minute to explain something, people will feel more like you're doing something in their best interest.
Right, right.
And if they understand what you're doing, they're more agreeable to it.
And I mean, and listen, that's why, I really appreciate Pastor Belton's leadership in this, right? Because, even though we're being we're being playful, we're telling these real stories. There is that real disconnect between people of color and their health. And when it comes to the reality of how dangerous, these particular things that you guys deal with on an everyday basis, it doesn't click. Like I said, I'm a diabetic. And I still eat sugar. You can't tell me I can't have no Louisiana crunch cake. Like, let's keep it real, And so, I haven't gotten to Mr. Smith's reality yet on what he's been dealing with. And now my 17-year-old son has diabetes, and it was a harder pill for me to swallow. So before I lose Brother Shock again, you've heard a lot of the pieces. I need you to get into the conversation of the psychology of you throw whatever you want at the wall, and you start with it, because I threw a lot of stuff out to kind of basis your answers. But I do think, before you fell off, we talking about Dr. Winkler and Dr. Quaino about, the machismo of doing this, of having these things done. And so I want you to bring that up. Talk to me about that a little.
Okay. Well, first off, I want to say that I certainly take better care of my health than I do my Wi-Fi. So I apologize to you. And I know that what I'm about to say must be that important for me to keep coming back in. So, hopefully it's worth the wait. But in terms of the machismo, especially in a lot of our cultures, there is certain ways that we look at things, and we don't want to be a part of certain things. There's a saying on the street, which is a somewhat offensive term, which is no homo. And a lot of brothers believe that if certain things are done, then that aligns them with this particular line of thinking.
Did he freeze? Oh.
So they would rather avoid certain things than to take better care of their health. If they know that this requires
when Shaka comes back, he's gonna come back with no tie.
A
there you
finger
go.
in the rectum, then no matter what the situation is, they're not gonna be a part of that. So we have a hyper mask, but that same bravado does not enter the space in terms of health and taking care of yourself. So if we look at things from the standpoint of taking care of ourselves, I think that we would probably be a lot more assertive in terms of I'm hearing a little bit of static on my end. Does everyone hear me clear?
Nope.
Can everyone hear me?
No, we can hear you. Take the tie off. Maybe that's what is going on. Take the tie off. You're free. You're going.
I'm assuming that you hear me, so I'm gonna.
Now you're sticking. You're like a little robotic.
It's far easier for people to.
No, he's freezing again. Just for a little. Go ahead. Yeah, I'm sorry. Go ahead.
Yeah, just in terms of walking into your doctor's office and seeing someone that you think perhaps you may not be comfortable with examining you in that way, you're the customer. You go find a doctor that suits your needs. If you want a male doctor to do your colonoscopy, go find one. You want a female to do it, go find one. You want somebody to speak your language, you speak Spanish, go find one. You have the right to those preferences. And there's the internet has made the world very small, and you can essentially find whatever you're looking for.
I mean, but so my only pushback to that, right, is because one of the questions earlier talked about the lack of understanding of insurance, the lack of availability of great doctors like you guys, because I mean, look, you guys are great doctors. And so when you're stuck with the process of you can't choose, how do we now create the narrative that your health is more important than what the person that looks like that's serving you? And I think that's where you guys as doctors, you know, you always have the answers, but I think some of that reality is where we are with people.
So you do have some leeway with choosing, right? You can always, if you have insurance, you can request a list of doctors and whatever specialty you're looking for, and choose from that list. You can get their names, research them, and make decisions that way. Of course, there's circumstances where these things are limited, and you don't have that much say. But yeah, that's unfortunate. But I think, you mean in terms of access to, like, getting to the place to go to see somebody you would like to see?
Yeah, I mean, look, we don't always have the choices, right? And I'm just saying, because again, we sometimes use excuses, much what Shaka was saying before the point, that we sometimes use excuses to create barriers to our healthcare. And so for the folks that are listening, the folks that are on, yeah, look, you have access to Dr. Quino and Dr. Carpenter and Dr. Winkler. But I'm saying, if you don't, as doctors, like, you know, how do you now still push the agenda to say, listen, your health is about you, right? Like Diane had a choice to say, yeah, this wasn't a doctor, but her health was about her. And sometimes you got to be stuck with that mechanic who keep messing up your car, but at least you got to go to the mechanic, because again, it's part of the stereotype, is about a part of the uncomfortability. So that's why I was just really trying to bring that conversation into folks, because, you know, one of the questions was, you know, does Dr. Quino take certain insurance? Dope, you do, but what if you didn't? You know, are you going to now push it down the road because she's now a validator for you? You know, and I'm just, you know, I know I'm throwing a lot of softballs, but I'm going through a community thing.
I get it. You know what's funny? So recently I had a colleague of mine's patient ask me, because she felt uncomfortable asking my colleague, who was not Black, that she wanted a Black breast surgeon. And so I am not a breast surgeon, but I took the time to, you know, put some emails or text messages out there, and I got a great reference from her, and I gave it to her. I think, if somebody wanted to see me and they couldn't see me, and they said, "Oh, Dr. Q, can you find somebody like you that I can see, that you think that I would like?" I'm certainly willing to do that. I mean, I don't think I know a doctor that would not participate in that conversation, but I mean, I might be in a special space.
You are in a special space, sis.
Right. All y'all, really.
That's all facts.
One of the other questions that came up was just really about the education of it, right? And so folks who don't have the ability to get on to this Zoom, how do we now look at, what do you guys do in the community? What do you guys do in terms of your networks to kind of get it to the layman side of it, right? How could the congregation of First Baptist kind of speak to what you guys are saying, even if they didn't get on to the Zoom, you know, because how do we meet people where they are at this point?
Well, I'm gonna put a plug in for primary care doctors. So I think everybody should have a primary care doctor. For men, that's always essentially an internal medicine or family practice doctor. For women, my understanding, depending on your age, is that it could be an internal medicine doctor, and a lot of times gynecologists provide some of that care for women. But you need a quarterback that can assess you on a yearly basis. So everyone knows a primary care doctor or has passed one's office somewhere, okay? And even once a year, if you have no insurance, you can come out the pocket to check yourself, okay? I mean, I hate to put it in these terms because I know people have financial challenges. I don't want to be insensitive to that. But, you know, if you can make it and pay your Verizon bill, your whatever bill, you could do this for yourself once a year.
Could I just ask you to maybe dive just a little bit deeper in the primary physician? Like, just break that down just a little bit more in layman's terms. Because I'm only saying that because you have now the culture of going into these quick spots, the MD
urgent cares, yes,
urgent cares, right? And people think, let me run into urgent care real quick, and like, I went to urgent care and I'm good.
Excellent point.
Yeah, very good point. Yeah, no question. So the urgent care has very little interest in follow-up. Should they find anything, their goal is to address an issue at that moment and get you out of there, and that's it. As far as, all right, well, and they will tell you to follow up with your primary care doctor. If you have none, then who do you follow up with, right? So the goal of the primary care physician is to be that gatekeeper, that quarterback, as Dr. Winkler mentioned, who's going to direct your care across all things, so whether you have a rheumatological issue or a heart issue or gastroenterological, it doesn't matter. It's like whatever it is, or you have no issues at all, but we're just screening you. That's where you come, because you're not going to get screened at an urgent care. They're not doing that. They're not looking for your other issues that could be underlying. So that's the importance of seeing the primary care doctor. He's going to coordinate everything in the background and then punt the ball to the specialist when things are out of his scope. You know what I'm saying? So he'll escalate the care to whoever he has to. I personally, I tend to, understand some of these things, these social issues. So I am intentional about sending Black patients to Black doctors if I have that option. Obviously, there's less physicians that look like us, so it's a lot more challenging. But I try to be mindful of those things. So I think it's important that you have somebody that can also be mindful of your race and ethnicity.
All right, and so we're gonna.
Sorry.
No, go ahead.
I just wanted to mention that the Cancer Services Program is available for people who do not have insurance at no cost, and it is a New York State program. The requirements are that you must live in New York State. You do not have health insurance. Have health insurance with a cost shared that may prevent a person from obtaining screening and or diagnostic services, meet income eligibility requirements, and meet the age requirements. And they screen for breast, cervical, and colorectal cancer screenings and diagnostic services at no cost. Every hospital has them. And so if you go to the Department of Health's website and look up CSP, which is Cancer Services Program, it will give you like all the information. So please don't feel like I don't have insurance, I can't go for a screening. The state has put together a fund that I advocate for every single year that they keep putting money into so that folks with no health insurance for whatever reason can still get screened for a lot of these preventable cancers.
Also, man, we keep losing Shaka, but I do want to say to the listeners too, right, that the primary care physician is a very important process in healthcare, because you're going to get that in emergency room bill. The urgent cares aren't going to take care of you. And, these are things that you can schedule. So when we look at Black health outcomes, the reality of it is that if we don't take advantage of these primary care physicians, then what ends up happening is that we get caught in the back run. Shaka is back. Shaka, just jump in, brother. Just jump in.
All I'm going to say is this. The level of persistence, every time I get knocked off of this show, I come right back. That is the same level of persistence that you brothers need to have in terms of finding out about your health and not allowing anybody to turn you away. So I'm not sure how much time I have, whether I'm going to get kicked off again. But every time you see me get kicked off, know that I'm coming back. And that's the persistence you need to have in terms of your health. And I think that's the best thing that I can possibly say at this point in time.
Awesome.
And look, the Lord kept you on a little longer. You better keep talking, brother. You better keep talking. But in reality, see, there he went again. Wow. And full disclosure,
he did his thing though. He did his
Shaka is a deacon, So I don't know, Pastor Belton, you're gonna have to pray a little more for what's going on with Shaka's. But I told you, you gotta take the tie off. But Shaka is correct, right? Listen, I'm a black man who, I understand what I go through. I have no issues talking about. I went through mental health to a therapist when I needed it. I went to Dr. Quenu with a dream that I had, and I said, "Yo, I'm scared. Let's do something." I'm very grounded in having my 2 feet down. What we do have to realize is that every issue that we do have is a temporary thought process, but our health turns into a long-term issue. And so everybody that's been on this panel has been talking about how important it has been to look at health. I tell folks, health is never your priority until you're sick. And in some cases, then that's a wrap. Shaka's back. So jump back in, brother, because now you're hitting home runs and walking off. So go ahead. The persistence is there, but really try if you can to get into the mentality of, or how do we balance that? How do we balance the issue of it? Shaka, you there?
Well, I think it's so much easier for people to. Yes, I'm here. Okay. It's so much easier for people to hold someone accountable than to hold themselves responsible. So for most of.
So what he was saying is so much easier to hold someone else accountable than yourself responsible, and that's the reality. I'm gonna be Shaka part 2. But the reality, he's right, because again, if you don't walk to that doctor, if you don't ask the questions, if you don't realize that something is wrong before it is wrong, then, I've lost a lot of good friends to issues of not wanting to even find out what's going on. And, the reason why Pastor Belton is a great servant in this is because he's creating this forum with a dynamic panel, because I didn't even know y'all was so dope when I was looking at all the emails. But it's important that, you're seeing every aspect of life, right? You're seeing an educator, you're seeing a barber, you're seeing 3 different people who take care of each other. You're seeing someone who understands the mental health aspects of it. But these are folks that are there every day if you need them to be, but you got to make the phone call. They can't call you to know that you're going through some things. And so from that standpoint, Shaka, like, how do you then create that pathway for yourself? How do you break out of being your own worst enemy?
Well, I think you actually are the best person to know about yourself. So most of the time,
you know what? He's going to look back on this day and be so upset in a good way, though. I don't know. Is he in a basement or something? Listen, I don't know how much. Oh, here he comes again. But I don't know how much time we have. But please, all of the doctors have put their information in the chat. If you don't need their particular service, do rely on them as a resource. Because giving their time and energy to something like this is very important. Because God knows, I know all of them probably worked 13-hour days a day and decided to come on to this thing. Brother Smith, you ain't put your barbershop in the chat because some of us do need a haircut.
All right, so full disclosure, I am only a barber by name, so all of my handles is Zaki the Barber. I'm currently a policy entrepreneur, so I do a lot of work in the criminal justice reform realm. So I currently have a bill sitting in legislation now around criminal record expungement to address a lot of the harms that mass incarceration has done to our city. And I mean, we can talk about some of that offline, being that you are running, during the Brooklyn Borough, the presidency candidate. We definitely should have a conversation about that, because that is real. Brooklyn is number 2 in the most individuals incarcerated, while 75% of the prison population came from 7 neighborhoods in New York City. Mm-hmm. And so that's the work that I do currently. So my org is Next 100. So it's Smith at thenext100.org. Also, I just wanted to briefly add around, death is real. Like, you know what I mean? And a lot of times we don't look or think about death in the way that we absolutely should. And a lot of our people and our community is dying from things that are preventative, that can be prevented if we just take care of ourselves. And so a lot of times we don't think about those realities. And what happens is when we leave this place, when we leave this world, we leave the responsibility of that on our loved ones. Your wife, your husband, your mother, your father now has to sit across from the funeral director to plan your funeral, right? They have to deal with the reality of this, right? And so we also have to look at those things too. And while we're thinking about our fear of the uncomfortability of getting an exam, think about the uncomfortability of your loved one having to actually bury you because you decided that you did not want to take an exam, because you had some other thing going on in your head about what it is associated with. So I want to end on that note. And thank you so much for having me here this evening.
And so, because you guys know I'm a late host and stuff, part of where we do need to talk about is some of the things, again, that caused me to go to Dr. Quino. So I want to say, do we find that people who get prostate cancer and colon cancer, do they get that mixed up?
Yes. I often get men in my office who said, I've had a colonoscopy before. And I say, really? So what happened? He's like, the doctor put their finger in my rectum, and that is the prostate cancer exam. So those are not the same exam. Prostate cancer and colon cancer are two different entities, okay? Prostate cancer affects the prostate. And as Dr. Winkler said earlier, the reason why I think people get it mixed up is because of the prostate's location and how the doctor examines the prostate. Yes, it's a finger in the rectum, but it's not located in the rectum. It's situated right in front of it, but you can feel the prostate's contours through the rectum. Your colon is about 5 or 6 feet long of large intestine, and colon cancer screening is meant to examine that those 5 to 6 feet, and particularly if it's done with a colonoscopy, to remove precancerous lesions called polyps, and thereby in the long run decrease your risk for developing colon cancer.
Question.
Go ahead, I'm sorry.
Well, because you brought that up, right? Because too often people say, oh, my colon, but it's your intestine. Where did we get colon? How did colon become in the intestine? Because I mean, a lot of people, I'm sure, are confused about when people not understanding that. Could you explain what those were? I know that wasn't in the questions, but I had to ask that.
Oh, sure. So you have your small intestine and your large intestine. The large intestine is also called the colon. That's it.
Oh, okay, cool. And so I know in other communities, the screenings were at 50 years old. What are we looking at? I know Dr. Carpenter talking about some PSAs at 40. What are we looking at in terms of getting colonoscopies or being eligible for them?
Okay, so to make it easy, just 2 days ago, the United States Task Force on Preventative Health formally decreased the age of screening for everybody to 45. Black, white,
wow.
Puerto Rican,
Everybody.
Yes, 45.
So how does that, and again, if they went from 50 for other communities and 45 for ours, why didn't they drop ours? I'm like, not to say, yeah, why are we now with everybody else when we're seen as higher risk?
Yeah.
So those recommendations are made on information gathered about colon cancers for several years, statistics. And based on those statistics, they make those recommendations. Okay. Does that mean that it's impossible to develop a colon cancer less than the age of 45? No, that's not what that means. But it's taking the general population whose average risk with no family history, they found that screening at 45 decreases their risk. The reason why they decreased the age from 50 to 45 is because the data over the last 10 or plus years suggests that there's more colon cancers, especially rectal cancers, in people the age 35 to 55. So the number of those cancers have increased over the years. And so that's the reason why the age of screening has decreased to 45.
So this is an interesting question specifically for our men. I had a colonoscopy, but walk me through the process. Walk me through that 24-hour, 36-hour process you had me go through. Tell the world what they should expect when they want to do that.
So you should expect to, in most cases, initially meet your gastroenterologist as a consult, so they can formally discuss your health, what medications you take, and to make sure that the colonoscopy is the right test for you. There's other testing options, and we can talk about that later. And then once that happens, you schedule your date. You need to make sure that someone is going to be available to pick you up after your procedure. During this COVID time, we do COVID nasal swab testing within the 5 days prior. Just a couple of days ago, we actually dropped that for people who've been vaccinated. So that's the little added snafu in all of this. The day before the procedure, you will fast on a clear liquid diet. For most, if you can tolerate it. For some people who can't go that long, we say it's okay to have a very small, limited breakfast the day before the procedure. Otherwise, it's a clear liquid diet fast. And then you take some medications, depending on what your insurance will pay for. There's about 5 different regimens that we can prescribe. And the whole goal of those medications is to get all the stool out of your colon. Okay, your stool needs to look like urine, clear and yellow. You come in, we put you to sleep with medications. You're asleep for the whole procedure. I put a camera with a light at the end into the rectum and move around the whole colon. If I find polyps, I take those out immediately. If anything looks abnormal, I'm able to take biopsies. And then we come out. It lasts about 16 minutes. At most 20 plus or minus, just if you need extra things done. And you wake up immediately after the anesthesia wears off. Most people don't really experience any pain. There may be some discomfort from gas. We put gas into the colon just to open it up so that we can see between all of the folds. If you pass that gas, you're good and you're ready to go. And your biopsy results are ready within the 2 weeks after the procedure.
Well, I was gonna say, what are some of the signs that, I know there's sometimes no signs, but what are some of the things that may be abnormal for a person to say, you know what, maybe I need to get this checked out?
So, I thought what Miss Diane Nathaniel pointed out about her experience is, and this is a dangerous assumption that people can make, that if you have anemia and you're a woman, that it's automatically is due to menstrual losses. Anemias always need to be investigated. You need to know where that blood loss is coming from. Just because you don't see blood in your stool doesn't mean that there's not a microscopic amount of blood in your stool that's being lost on a daily basis, which could lead in the end to an anemia. So anytime there's an anemia, it needs to be properly investigated, its source needs to be identified, and then it should, be treated accordingly. So if you're a woman and you have iron deficiency anemia, talk to your doctor. You might need a colonoscopy, you might need an upper endoscopy, you might need procedures to look into your small bowel, and make sure, we're ruling out what we need to rule out.
And in what untreated, right? There are stage 4s, but you always talk about catching cancer early, catching these things early. Catching it early means what for folks? If we could just talk about it in layman's terms, catching early means you live. Catching it late, not everybody's going to be as blessed as Diane. Should we just do this as a procedural process?
So catching it early, to me, ideally means that finding polyps that have the potential to become cancer but are not yet cancerous. Finding those polyps early and just taking them out before they're even an issue. Once you have a diagnosis of colon cancer, the 5-year survival rate really depends on the stage. There's limited stage or stage 0 cancers. That means that you have a polyp with a little bit of, abnormal tissue in it, and if it's removed with the colonoscopy, then you don't really require any further treatment. The larger those polyps get, the more abnormal the tissue becomes, and they can penetrate through the skin of the colon and go into involve
The
neighboring
liver.
muscle tissue, lymph nodes, and then spread through the lymphatic system to other organs, the liver, and so forth. And the further away it's spread, the more limited the survival is within the 5 years.
So I'm just going to ask our host, can I get 2 more minutes to, because I know we're about to shut off, but I just want to really get another minute with Dr. Quino and then have the guest say goodbye. But really just, like I said, how often should someone just even do it? Diana spoke about a fit test, but how often should we do this process? Because, colonoscopies, urology tests, we need to do that often. How often is right to do stuff like this?
Okay. So colon cancer screening, once you hit 45, should be done. Okay. And I'm only talking about healthy asymptomatic patients who don't have a family history. It's a different ballgame if you have symptoms, if you see blood, if you have belly pain, if you're anemic. I don't care what age you are, you need to be evaluated at that point. Okay. So when it comes to just screening of asymptomatic, no family history people, then there's a couple of different modalities. The colonoscopy is considered the gold standard, the Rolls Royce of what you should do. There are other tests, and the colonoscopy, how frequently you do it, depends on the findings. If you have a normal colon, you can repeat your next colon within 10 years. If you have one polyp, it's 5 years. If you have like 2 small polyps, it's 5 years. If you have one really huge polyp, your doctor might choose to bring you back within 3 years or maybe even 1 year, depending on the nature of the cells. If you have a colon cancer, then obviously you get treatment and you repeat in a year as well. So the other screening options include stool tests. There's a FIT test, which is a little bit of an older test, and that test looks at kind of microscopic amount of blood in the stool, human blood in the stool. There's a little bit more of a sophisticated test called Cologuard that not only looks at the blood, but also looks at the presence of genetic material that is often shed by polyps or cancers or and so forth. If you are at all hesitant about doing any screening and you want to start with something non-invasive, that's fine to do, but understand if it's positive, you're going to need a colonoscopy anyway, right? If it's positive and you need a colonoscopy, the way our healthcare system is set up, your colonoscopy now becomes a diagnostic colonoscopy, and you have to pay into your deductible for it, right? So overall, if you look at the numbers, it's actually cheaper, even if you were a cash paying patient, to go straight to colonoscopy. But there's some people who have medical issues that might preclude them from receiving anesthesia. If you have a heart or serious lung disease or something like that, procedures can be done in a hospital-like setting where you can be better managed, but you might choose to do a non-invasive test for those reasons. Convenience, right? So we're Americans, and convenience is part of our life. So yeah, if Cologuard or a stool test is more convenient for you, and it's the best option for you at whatever period of time, that's also an okay choice. Just as long as you do something, you have to do some kind of screening.
Right.
I'm going to make one more quick plug. Another reason to see your primary care doctor, because a lot of times to get to a specialist, you need to see them first and get a referral.
Right.
Often when we need to do something, we send you back to the primary care doctor to make sure you're good. So yet another reason.
Right. Absolutely.
So, jokingly, everybody sees that Cologuard commercial. They don't want a little toilet bowl running around with them. So go see a true a GI doc. So we're going to wrap up, but I'd just like to give everybody about, 30 to 60 seconds to give your closing statements. And then I think Pastor Belton's going to cut the cord. So Dr. Quano, since we ended with you, we'll start with you.
Colon cancer screening starts at the age of 45. If you have a family history and that person was affected before the age of 60, you need to see someone ASAP. You need to get your colon cancer screening 10 years before your affected relative.
Okay. Dr. Winkler?
Go to the doctor. Period. Just go to the doctor and ask questions. Starts there.
Mr. Daniel?
I am your neighborhood family patient advocate. So if you need some help, please contact me. Also, a colonoscopy saved my life. It can save yours too. We fought really hard for this age roll down at 45. Truly needs to be 40. But in the meantime, if that is your age, please go, go, go. It's the best sleep you'll ever have legally. And I promise you'll lose 5 good pounds. And in the end, it could save your life.
Listen, when I came out of mine, I kept asking Dr. Quano if I farted on her. So, brother.
I have that on video, by the way.
Blackmail after I win, Brother Smith. Blackmail after I win. But please, your closing remarks.
Yes, and not a cliche statement, but your health is your wealth. If this pandemic hasn't taught us anything, it is very important for us to be healthy. And please make sure you go to the doctor. You are not a homosexual if you get a prostate exam. Just be clear. You are absolutely not. So get that garbage out of your mind, and take care of yourself.
Dr. Carpenter?
Yeah, so, the good book says we transform ourselves by renewing our mind. And I hope that through this conversation, that's what's happening here, that we are having some new thoughts and having some new approaches to our own personal health. It's truly our own responsibility. The 15, 20 minutes that you get with your doctor, that's cool. But when you step out into the world, it's all the rest of those decisions are up to you. So I really want to just hope that everybody just really makes this a priority. It should be, up there with the top ones in your life.
Shaka?
An ounce of prevention is worth a pound of cure. The more that we spend in terms of prevention, the less we have to do on the back end. It's important if you didn't hear anything I said today, and you probably didn't, understand that it's important for you to be very persistent in terms of your health. Don't let anything stop you, distract you, or stop you from going to the doctor and finding out exactly what is going on with you. There is a cycle with everything. So when you go to the doctor, make sure that you take appropriate notes. So when you feel a pain, write down exactly what was going on when you were feeling that pain, how long you were feeling that pain, when it stopped, whether you ate, whether this happened in the morning, all of these different things. And after you begin to chronicle your own notes, you'll see some commonalities in exactly what it is that you wrote. So when you go to the doctor, now you can be a partner in your own wellness plan, because you can give them just as much information as they are giving you. And now you know exactly what questions to ask them. And now their prognosis is all the more stronger because it took some of your input. I think I did. Thank you.
You sure enough did, brother. Also, if you can, could you just put your information in the chat so the listeners could catch up to you? Also, Shaka does a Instagram live that is dope. I haven't really caught a lot of it, but I think that we got to support our brothers where we are. But he does a real good conversation with it, and him and I talk a lot about just men's strength and men's understanding. And we were supposed to do a segment together, Why Black Men Don't Cry, but the campaigns got me held up in that. Look, I on behalf of Pastor Belton and the First Baptist Church of Brownsville. Oh, there he goes. Good, because I didn't want to speak wrong for you and get some scripture wrong, my brother. So you go ahead.
Listen, first of all, I want our audience to pop in the chat, give our panelists a great hand, give them a great up. The information that we've received tonight, the education that we've received tonight, is absolutely paramount and absolutely great. There are a lot of resources. These doctors and clinicians can help in ways that we can't help ourselves. So I want to thank each of the panelists individually and collectively for taking the time. Thank you, my brother Kara Edwards, for moderating for us. And I hope that we can do this again. I think we're supposed to take the gospel to the utmost parts of the world. I believe as we take that gospel to the utmost parts of the world, we have to take the healthcare portion of it as well. I believe in holistic ministry where we not only want to treat and heal the soul, we need to heal people physically as well. And we can use the digital platform to reach people who we normally would not reach. So thank you all so much tonight. I pray that we can get together and collaborate again and do another segment on something, other than men prostate cancer or prostrates and colons. Mr. Fair, we're going to give you a Wi-Fi colonoscopy or something. Dr. Cornell, Dr. Carpenter, and Dr. Winkler, you all get ready. He's going to be bringing his Wi-Fi in for a checkup there. But again, thank you all so much. I'm working hard to figure out how we can make First Baptist Church of Brownsville a vaccination site. We've done some COVID testing there, but also we want to make it a place where people can come and get educated on their health. I need help. Brownsville is a food desert, and our people are not eating healthy. So we want to encourage them. And thank you all for being so open and honest and transparent in your dialogue so that our people will know it's okay to go to the doctor. It's better to know than not know. So again, we thank you so much. We thank our audience, and hopefully we can get an even bigger audience next time. Amen.
So Mr. Smith,
Thank you.
You know when the pastor says, "Look at your neighbor," he say he's talking to you. So I think he's talking to me and you. So we gotta get some food over there. And Pastor Belton, I'm coming to church on Sunday, 8:30 service, right?
Yeah, 8:30, 10:30. Show up.
No, I'll be there 8:30.
I'll be there to send my Easter speech. Okay. All right. But listen, thank God for you. If you all don't mind, I would like to pray with you just briefly, asking God to listen to you and your different endeavors. Amen. Father God, we thank you for tonight. God, we thank you so much for the opportunity to come together and collaborate as a people, that we can reach our people and reach people beyond just our four walls, God, that we can educate people about their health. God, I pray this information has fallen on good ground and that it will produce great fruit. I pray for each individual that's represented here tonight, and I pray for their families. God, I thank you so much for the expertise and the knowledge that you've given them. But most of all, God, I thank you for the heart that they have to want to share it. I pray, oh God, their blessings upon them. Lift them, use them, empower them, and strengthen them, God, after a hard day's work. We thank you. We glorify it. As in Jesus' name we pray. Amen.
Amen.
God bless you all. It has been awesome. Thank you so much. Amen.
All
All right. Thank you.
All right.
Thank you for being so
Good night,
patient with
good
my
night.
wife.
Thank you so much for having me,
We
guys.
love you, Shaka.
Have a good night, everybody. Stay safe.
Good night.
right.
Amen.
Good night.